housekeeping items I'd like to run through with you. The first is today's format. It will be a 60-minute webinar. We have 3 presenters today. We will have a few slides towards the end. You may hear the audio through your computer or by dialing into the conference call line. On your right-hand side, question and answer pane, navigation pane, will have the audio information for you. All of the attendees have been muted, so if you have any questions, please feel free to send me a direct message via the chat or the question and answer feature, and we will ask those questions on your behalf during the question and answer period. If you have any technical problems or questions throughout the webinar, feel free to send me a message through the chat feature, and I will be happy to answer those questions individually throughout. We will have copies of the handouts of the slides that will be sent for you later today. And we do ask at the end of the webinar that you complete a short 5-question survey. It helps us make improvements as we go along. We do have CEUs available for today's webinar for assisted living, residential care, and nursing facility administrators. So following the webinar, you will get an email, and you may request a copy of those CEUs by replying to that email, so please watch for that. We are recording this webinar today, for some housekeeping items for those listening to the playback, please note that no CEUs are available for the playback version, and updates and changes are being made frequently, so some of the information that you are hearing today may have been changed since the live broadcast, and you are welcome to connect with OHCA throughout the time after the webinar to be updated on those changes. So without further ado, I would like to introduce our first presenter today is Jack Honey. Jack is the Administrator of Safety, Quality, and Oversight with DHS. And Jack, you have the floor.
All right, thank you, Melody. Can you hear me?
Yes.
Okay. All right, so thank you for joining today, everybody. I apologize for not having slides, so you'll have to just endure my voice for the next set of time. I want to very quickly run through some updates about COVID-19 and the state's response to it in our license settings. I will try to move fairly quickly through it, so we'll have some time to answer your questions. I know there are a lot of specific questions. If we do run out of time, we will have those questions gathered, and I will get responses out to people as quickly as possible. So first of all, as you all know, the original idea around COVID prevention in our facilities was placing the visitation restrictions and then placing the executive orders on those facilities where there was suspected or confirmed cases of COVID. To date, we have placed approximately 525 executive orders. The vast majority of those have been subsequently lifted. Currently, there are about 40 or so on buildings around Oregon. We feel that they have been fairly effective at helping facilities limit traffic in and out of the building and allowed them to practice appropriate infection control to manage and contain that infection within the facility. There have been a few points of confusion along the way, so I just want to clarify a couple of points and remind everybody that we are here to help with questions at any time. We have had some confusion around the restriction of admissions on executive orders. As you can imagine, it's very, very important that we are limiting admissions and movement in and out of those buildings that have confirmed COVID infections. However, I want to very clearly point out on the executive order, it does say no admissions or readmissions without prior written approval from the department. So, and now as we're moving forward and we're learning more about COVID, we have a better understanding of how admissions can at times be done safely. We are still standing firm that we will not be bringing COVID positive individuals into COVID negative facilities. But if you have an executive order and it's got the restriction of admissions, please be sure to communicate with us around your admission and readmission needs. Also, make sure that your staff and community partners accurately understand the limited visitation policies in place, and that extends to essential visitors. Essential visitors do include medical providers and vendors. We've had some concerns from around the state, although very few still, of people, individuals such as physical therapists and other medical providers being denied entry when they are providing services. So just a reminder that those professionals would be considered or could be considered essential visitors. And we have been trying to do our part to inform and educate those organizations so that they can make appropriate decisions about whether the visit itself is essential. But physical therapists should be considered essential visitors in our buildings. We have been trying to ease some of the criteria for placing and lifting the executive orders, and this is based on increasing understanding of the COVID virus itself and on continued guidance from the Centers for Disease Control. So again, and this points back to what I was saying about restriction of admissions. We're learning a lot more about how to appropriately practice infection control. So we will continue to place the executive orders. We will continue to place the restriction on admissions. But as we learn more, we're able to do more. We're able to lift them a little bit sooner in some cases. And we're able to look at case-by-case basis on a case-by-case basis at each situation to help make better decisions about how to manage your buildings when they do have the COVID virus active within them. When the executive order was placed initially on pending tests, we were and will and have been lifting them immediately when test results come back. If an executive order has been placed on a confirmed building, on a confirmed case, the criteria for lifting we're finding will be more complex. So we are currently working together with OHCA and some other groups to determine how best to evaluate the safety and appropriateness of lifting those restrictions in buildings. Many questions, for example, the layout of the building, the ability to appropriately practice isolation practices and other infection control. Primarily, did COVID positive individuals in a building recover or move out? And so we've had cases where we're able to lift the executive order very, very quickly, and others where we have to meet some other sets of criteria together with local public health and OHA. So we just am kind of giving a heads up about that right now. We're working on some better guidelines, but please feel free to be in communication with us regularly if you have questions about that. And if you do have a building with COVID positive and are ready to be relieved of those restrictions, we will be in touch with you very, very frequently to go through that process together. I wanted to take a moment again to remind people about reporting requirements. A reminder that all new cases, new tests, and status changes must be reported to SOQ and to the local public health. It is very important to report, especially now that we're seeing more testing becoming available. In some situations, some facilities have been able to request and access precautionary testing for large populations of staff and residents. I want to let everybody know that having this kind of precautionary testing performed will not result in an executive order being placed on your facility. So we really want to continue to encourage reporting with all tests. And if you're contemplating taking an action or doing something as a precautionary measure to provide safety to your residents and are concerned about a restriction of admissions or executive order, please by all means contact us in advance and we can talk through it. There are many, the idea of the executive order is not in any way to be an obstacle to you providing appropriate infection control and safety to your residents. So that being said, in terms of the reporting requirements, we are becoming more and more aware, as I think many of you are, that there are many different agencies and work groups out there gathering information and working on various aspects of the COVID pandemic. We are hearing reports that some administrators and facility staff are receiving multiple questions throughout the day sometimes the same questions coming from different groups. So I apologize for that, and we are working hard to streamline and minimize those disruptions. We do welcome your calls if you have concerns or questions about that. In some cases, there are different arms of different organizations working on very important pieces of this pandemic, and we're not always aware of who's calling whom. So we are very hard at work on streamlining those efforts and developing a process by which you will be relieved of as much of the burden as possible, so that we can have limited contact with you, so that you will have time to focus on what's most important, which is providing the quality care and ensuring the appropriate infection control practices in your building. So for now, I do apologize, just bear with us. I know there are a lot of questions flying around there. I will remind you though that SOQ, local public health, and OHCA, as they are developing different programs and working, they do need to have some measure of responsiveness if they've got questions. So we will, as soon as possible, get that down to fewer points of contact. For a general overview of what we're doing right now at SOQ, for all of the buildings, all of the providers out there, both individual buildings who have COVID infection within your facility and those who do not, just a quick reminder that we are available here at SOQ for questions, concerns, or guidance. Right now, we are online. We're live 7 days a week from 8 a.m. to 10 p.m. A reminder that we do have an evening and weekend after hours telephone, which can be used for any COVID-related questions at any time. That number is 503-586-9396. Most of our corrective action coordinators and policy analysts are working from home right now, but are available to assist you daily. So if you call during normal business hours, you may get a voicemail, but people are frequently throughout the day checking their messages, and you will get your call returned. For non-urgent questions, I would encourage you to use your program email addresses whenever possible. We're all here to help and to answer questions. We're getting more and more program managers and other individuals getting questions in their email, and that is perfectly acceptable, but please be aware that there may be more of a delay in response times there. Whereas if you use the program emails, we've got multiple people checking those throughout the day and can be working on getting answers and returning your calls, your queries. The two email addresses, I'm sure everybody have them, but it's for community-based care programs, it's cbc.team@dhsoha.state.or.us. And for nursing facilities, it's nf.licensing@dhsoha.state.or.us. Additionally, for facilities who have identified confirmed COVID cases, when a positive case is identified in your license settings, you should be contacted by your local public health office. The public health office will assign someone to monitor and work with those facilities. Guidance still states that 3 or more cases is considered an outbreak, and it is assigned an epidemiologist to work with the facility. SOQ will remain on board. We will still be tracking daily, and we will be working with you and your local public health to monitor your resources, personal protective equipment, and the ability to maintain infection control protocols. We'll be gathering data, etc. We know that by intent, by policy, what local public health is trying to do is maintain a daily communication with each facility where there is COVID positive. So we will at that point step back and work together with public health to make sure that there aren't more than that one call, but there may be times when the 3 of us will be on the call together. It is very important that information be shared both with SOQ and public health, but we will do our best not to ask for repeat information. We will be working on this collaboratively. with buildings who have positive cases. So all buildings with confirmed COVID now are also assigned a representative from SOQ that will be visiting buildings weekly. The intent in these visits is to be as unintrusive as possible. We will be making observations. We will be there to answer questions. We will be checking on PPE supplies and the use of PPE and appropriate infection control. The goal is to offer technical assistance on the spot. Additionally, for nursing facilities, I do want to note if there are any nursing facility providers, if there are significant concerns identified, it will require us to open a federal infection control focused survey. But for the most part, we have not seen that. The surveyors on site are able to do, so as I said, to do technical assistance with staff who have questions about the use of PPE. We're also taking a look at your supplies of PPE because then behind the scenes, we are able to put in requests and try to bump things up wherever possible if there are available PPE and supplies out there to make sure that you have the tools and the resources that you need. We'll also be looking at your staffing plans and talking to administrators to see if you have any concerns about your staff being out or getting sick. We'll try to look ahead with you for the next couple of weeks to ensure that you are able to fill the needs in terms of your staffing resources and can do some brainstorming and problem solving and work with other groups to provide some resources if there is that need for staffing resources. And finally, the other thing that we're trying to do is reduce burdens from you in any other areas right now. We are working on some ways to expedite some hiring and training, and I know that's been, some people have been waiting for that. We will be able to provide some more information about that very soon. Additionally, with the quality measurement data for our community-based care facilities, you may have already seen, but the webinars that have been scheduled for May are being canceled. Right now, I can't provide any real detailed information, but we're trying to just postpone some of that, and we're doing everything we can to keep your focus back on quality and safety within your facility. So more guidance will be coming out soon. Most likely you will see those training webinars coming back in the fall, and then we will be able to outline how we'll be moving forward with that data collection. And then finally, as I close, I just want to give a big thank you to all of you and to say how impressive it is overall what we've seen happening in our facilities. We know that people have been scared and exhausted and working very, very hard and doing all you can. And we do notice that and we do appreciate it. And a big thank you to all of your staff. As we start to look at Oregon reopening and we start to hear talk of the phased approach to reopening, I don't know about any of you, but I, for one, have seen, even as I'm driving down the street already, some out in the community, some people kind of maybe engaging in some unsafe practices. So I just want to encourage all of us to remain vigilant as we start to reopen the state. We will be keeping a pretty strong focus on our licensed long-term care facilities because, you know, as you know, we are providing care for such a vulnerable population in many cases, and we do not want this virus to get into the facilities. So please both rest assured and bear with us as we continue our policies for long-term care settings into the foreseeable future as we fully get through this COVID pandemic. We will work together with you and with OHCA and with other groups to develop an appropriate plan for returning to normalcy within our licensed settings. So with that very quick overview, I would like to open it up to any questions.
Please enter your questions using the question and answer feature on the right-hand side of your screen. Jack, the first question I see is, please repeat the after hours number.
Absolutely. Our after hours number for SOQ is 503-586-9396.
The next question, how many nursing facilities have had positive COVID tests since the beginning?
I'm afraid I don't have that data on my fingertips, but I can get some information and send that out.
Okay. I do believe that that information is included on daily COVID-19 member update emails that are being sent out by OHCA. So I recommend that you check that out as well.
And that, I'm assuming they're asking about cumulative, how many total
Right.
positive, yeah. Okay.
You mentioned proactive universal testing. We are looking to have that in our communities. What resources exist?
So all the resources for that would be discussed through your local public health office. And there's not a lot of information at this point that we have either. We know that there are not, as of yet, full supplies for everybody to test. We also know that licensed long-term care settings and healthcare professionals have been placed at the highest priority in terms of testing. And we have seen a few facilities who have asked and received blanket testing for everyone in their facility. But that would be arranged. I would encourage you to reach out to your local public health office for more detailed information about that.
Next question. Is there a timing to open facilities to visitors, including non-essential visitors?
A timing? I don't quite understand the question.
I believe what they mean is, do we have a timeline for when non-essential visitors can start visiting their families again?
Okay, so for all facilities statewide, non-COVID positive, the visitation restriction that is placed on all of them, we don't currently have a timeline. It will be in place at the very least through the end of the governor's executive order. And that's part of, I think, the exit strategy that we're working on, or will be working on with the Oregon Health Authority and other groups for kind of returning to normalcy with our NIFs and CBC facilities. Unfortunately, I don't have a clear answer at this time.
Can you please repeat what resources will be offered for staffing plans?
Staffing plans. So meaning if facilities are facing concerns about their staffing, perhaps having shortages, this is a tricky question because, as you know, this is there's a scarcity throughout the state on this. But what we have done with a couple of facilities is just when we are aware of perhaps a high number of COVID positive or pending among staff, or for any other reason, a shortage of staff, we have pulled some people together to try to reach out to every kind of staffing agency, to other facilities, to other resources. We've got here at DHS, we have an emergency planning group put together. So it's, again, we don't have a solid pool of available staff or any kind of real solid resource to offer, but rather a group of people that can work on finding and trying to get additional staffing resources for people where that need is, so you don't have to do it on your own, and so that you can keep your focus on other work while that's being done.
Next question is, could you please speak to the administrator alert that went out on Friday night about disinfecting belongings for days? How would this directive apply to mail or things families are dropping off for the residents for Mother's Day, etc.?
Ooh, that is a very good question. And I do not want to risk saying something that may be taken as definitive because the specifics of the infection control, I really would want to. We partnered with OHCA in that. So I know that that's going to be a relevant question very, very quickly, if not already. So I will get an answer out with some updates on that provider alert as quickly as possible. But I do want to get some more input from some infection control specialists and epidemiologists.
And will you please share a bit more information about infection prevention surveys for facilities that are currently COVID-free?
I'm sorry, Melody, could you repeat that?
Absolutely. Will you please share a bit more information about infection prevention surveys for facilities that are currently COVID-free?
So currently, we aren't going out and doing infection prevention surveys. We did have some off-site reviews being performed. Right now, we recently got some additional direction from CMS about doing focused infection control in nursing facilities. And so our focus has shifted a little bit there. We are going out into every building that is COVID positive. And we definitely want to maintain some kind of contact and support for those buildings that are COVID negative. So we need to, I think we need to, I think we'll need to send out a little more guidance on that and on what the plan is. We are not currently going out and doing infection control surveys in non-positive buildings.
Okay. And one final question. I know there are a number of questions that have been submitted, and we will have Jack answer those questions, but for the sake of time, we will be moving forward after this last question. But once we do have the answers to all of your questions, we will email that out. So thank you for your patience. If we as a company are looking at testing residents and staff, will DHS need to be notified?
Yes. If a company is looking at testing residents and staff, I'm assuming that you are referring to something done as a precautionary blanket testing practice. Yes, we would need to be notified that you are doing that. Again, in most cases, it would not necessarily result in an executive order or any kind of action, but we would want to know that those tests were happening.
Thank you so much, Jack. And I did want to let everyone know that OHCA does have resources on our COVID-19 resource page for commercial labs, resources for accessing that information. So feel free to go to OHCA.com, the COVID-19 information page for more details on that. So Jack will be hanging around if we have some time at the end for additional questions. But I would like to introduce our next two presenters, Kelly Odegaard and April Diaz, who will next be sharing some lessons that they've learned from the front lines of being providers during this unprecedented time. So Kelly and April, if you would like to unmute and show us your webcams, we would love to have you present next.
Great. You want to go ahead and pull up that first slide after the opening one, Mel? Okay. For some reason, part of it's blocked off. I don't know why that would be, but. I'll jump to mine because I can't see the whole slide now. For some reason, the left side is obscured. All right, well, at this point, May 2020, most of you have been there and back, and probably this is going to be old news. If there's a few things that you can glean out of this, then terrific. Some of us have been in the front lines and dealing with positive cases since early in March. So it's almost passé now, because at this point, all of our active cases have resolved. But these are some things that we learned along the way and we want to share. So I'm going to handle the first slide, and then April's going to correct me as I make mistakes and go ahead and fill in the blanks. It helps if my camera's got the cover open. Oh, April. Actually, it's better if I kept it closed, probably, in most cases. So obviously, the first thing you want to do is make sure you have plans well in advance. Most of you have done this probably since February or before for skilled nursing facilities. This is something that we do routinely with infection control practices. Some new twists a little bit along the way for the COVID-related pandemic. And you probably already made most of those adjustments. You need to have an updated pandemic policy that's going to have some things specific probably to COVID-19. Along with that, and hand in hand is the disaster preparedness review. You have your fire and disaster manuals in your facility have been required forever and ever. And there is a great checklist from Center for Disease Control that should be used while you're reviewing your disaster manuals and looking for specific things related to the pandemic. As we know, we've had copious amounts of guidance from CDC, CMS, OHCA, and every other acronym known to mankind, and they come out multiple times a day, and they quite often change direction. Many of you are well aware of the notification requirement that we have in skilled facilities for notifying families, where 1 minute it was May 8th, the implementation day. The next morning, it's May 1st. So we've had a lot of this movement back and forth. So you really need to be attentive to tapping into all your information sources for sure. Probably the biggest thing that everybody's well aware of is keeping it out of your building to begin with. That's obviously the best strategy if you can get away with it. We had the opportunity where it had already arrived in our building and then we had to contain the spread of it. But most folks at this point, with the elimination of non-essential visitors and the prophylactic use of masks for all staff, if you have even surgical masks or even cloth masks, to have all your frontline staff or all your staff wear those when they're on campus. You're doing your screenings of everybody who comes into the campus at least daily, if not multiple times a shift. In our case, in one of our facilities, we have 12-hour shifts, so it'd be a good idea to take temperatures a couple times a day. And that's true for anybody who comes in, whether it's a vendor or staff that may be from corporate office, or as some facilities have found out, surveyors, when they come and visit you, you want to demonstrate that you know what you're doing and make sure to screen them. Just because they have that badge on doesn't mean that they don't get screened in your facility. And that's anything that goes into a resident care area. Everybody's buildings are different. I know one of our campuses, you're a long ways from the care area when you come in the main door, which is the only one that's open now. But still, it's a good opportunity to use that space to screen people and make sure that we're not incidentally allowing a bug to come into the facility. As April and I were discussing earlier, with all the extra screenings, we're detecting a lot of things that we may not have caught. With extra chest x-rays, we're probably detecting a lot more UTIs than we might have caught because of a small variation of temperature that we're now watching very, very closely. So that would be something that you shouldn't be surprised by. Specific staff training on lots of issues, but specifically a use of PPE. Most CNAs, licensed nurses are very well versed in the use of PPE, but it's good to review the donning and doffing procedures of the equipment. And then quite often for some equipment like N95 masks that are reusable, to the proper disinfecting, the proper storage of those if they're being reused as well. So shortages on PPE are well known internationally at this point, and conservation techniques like reuse of equipment is something that if you have a number of cases and you have a number of people on full precautions, that you should be pretty familiar with at this point. One of them is to cohort any of your COVID positive residents, so they're in a common area. If you do that, then you're able to fully gear up with your precautions and then be able to meet the needs of all those residents on full precautions that are COVID positive without having to change your gear other than your gloves and doing hand hygiene. So it's a good way to make sure that you're conserving your equipment. Also considering doing multiple tasks when you go in and out of rooms, if it's meal time and med pass time and perhaps time to assist somebody to the bathroom and help them with other things, do all of those things all at one point. Certainly it's important to then, once you've trained your staff, to make sure that you're auditing them and you're observing your staff to make sure that they're properly using their equipment and following good hand hygiene. Lots of information on COVID. As we know, it changes all the time, but keeping our staff safe, caring for the caregivers is paramount. I think we jump into that maybe in the next slide, but making sure to educate our staff on how they can protect themselves and their families. The biggest challenge is, of course, our residents aren't going anywhere, but our staff are coming and going from work. They're going out in the communities. How can they protect themselves when they go to the grocery store? At this point, I don't know where you folks live, but I'm in West Salem. Probably 70% of people I see in a grocery store now are wearing some sort of mask, and some are rather creative. Also, I found it rather humorous to watch non-healthcare people utilize healthcare equipment like gloves and wear them all day long instead of changing them out and thinking they're not spreading the bug around. So kind of amusing for us who are in healthcare, have been doing it a long time. Obviously early on, and everybody's scrambling, one of our big challenges in our first building was the first nursing home in Oregon to have a COVID positive resident, was securing equipment. And that's going to vary early on. Hopefully that supply chain is starting to stabilize a little bit, but equipment starting with N95s should be used for anybody who is COVID positive. Ideally fit tested. An N95 that has not been fit tested is no more than an expensive surgical mask. Surgical masks in all other cases. Eye protection could be goggles that are disinfectable, reusable, face shields that can be reused and disinfected. Certainly hand sanitizer was one that there was a big run on because for the general population, lots of creative ways to make hand sanitizer now. It's really sad that they stopped making consumable alcohol to make hand sanitizer. For us in the industry, both are required. One of the things that we didn't think about too much was additional IV pumps in the skilled setting. So we had a lot of our residents that were COVID positive were on IV therapies and obviously needed more pumps than we had on hand originally. In addition to that, quite often they're going to have higher volumes of oxygen use. I know we have folks up on 6 liters or so, and maybe even higher on an intermittent basis. So looking at your oxygen supplies, concentrators, etc., was very important. Controlling and managing your PPE is critical. The first thing we did was to bring all those critical PPE into a secured room and where they were inventoried daily. You can then calculate what your burn rate is, how frequently are you going through those supplies and managing those. Predicting how many days supply on hand you have is really critical, and then making decisions about acquiring additional supplies. Where are your hot buttons? You may be great in 3 out of 4 categories, but that 4th one, you're running short very quickly, and you know you need to focus on obtaining those supplies. Communicating with your staff about how you're managing your PPE and why you're doing it a certain way, why you're using conservation policies. is talking to Pat Preston multiple times. He says, you know, we're in a situation with our supplies where we just can't pick up the phone and ask a McKesson or Medline to ship me a case of something. We are now applying third world practices in a first world situation. So we would typically never reuse surgical masks or N95s, but we're in a situation that reusing them is better than not using a mask at all. So that's something that obviously many of you have been dealing with, scrambling for those supplies. I don't have a crystal ball, but from what I've seen since the 1st of March to today, we're in a far better situation. There are a lot of new suppliers coming up. A lot of manufacturers have been ramping up, have been repurposed to produce PPE in the US, overseas, etc. And you probably have gotten calls now from lots of different vendors saying, hey, we've got PPE supplies for you. So you just have to watch out which ones are credible and which ones are reasonably priced as well. The last thing on this slide I'm going to cover before April takes over is the symptom review. We talked about it already, monitoring for symptoms in your residents and staff daily, at least, if not multiple times a day. Boy, you know, any fever, and April's got 99.5 or above. We use 2 degrees over baseline as considered a fever. Everybody's different. It puts things in motion. If you've got somebody who throws a fever, you know that that's one of the markers for COVID-19. Shortness of breath, certainly, and all the rest of them that you're well aware of. Those are all triggers for you to immediately isolate, immediately go to full precautions with your staff, to do testing if you haven't already, to verify it. Don't forget to rule out flu first. The first thing we did was rule out flu. We still have active flu cases out there. And respiratory viral panels is another thing that can be run very quickly and even simultaneously while you're pulling a COVID test. You don't want to walk past the flu, which is treatable, and suspect that it's only COVID. So just want to remind everybody, don't forget about these other bugs. And the droplet precautions are really critical. And the guidelines have changed ongoing with how long you keep people on precautions. I think now it's what, 10 days post symptom start, I think is what I read today. April, is that what your understanding is? And when someone, different terminology, when someone is active COVID, symptoms, tested positive, have symptoms, versus when they're recovered, a couple of different standards there. I know of 2, and I think you mentioned a 3rd standard today, April, when we were chatting. Non-testing standard, 72 hours symptom-free, or 10 days now post-start of symptoms, and then a testing standard, which has been up until today a double negative test standard. OHCA, through one of our facilities, they communicate with them frequently, explained that we've got a lot of situations where we'd have a negative test, and these are people 40, 50 days post, start of symptoms. A negative test followed by 2 or 3 inconclusives. OHCA is now giving us guidance that if you have a negative test and another inconclusive, you can consider that resident to be cleared, which means they no longer need to be on full precautions and when you're caring for them. So that's really good to hear. April, before we move on, any extra things that I forgot on this slide that you want to cover?
No, I think, Kelly, that was awesome. I think really, as I think you guys learned and we learned with our facility that ended up with a COVID positive, a few patients, is do not hesitate. If you have that small indicator, we set such low thresholds to setting the full precautions, droplet contact and eyewear. You can control possible spread. These residents, these symptoms are subtle. You're not going to get what you hear on the news for these really high, we didn't see anyways, significant onset shortness of breath, drops in stats. It was these little 99.5s, 99.8s, may have a cough. So keep your thresholds really low before you have, to set your indicator for protection. That's probably the biggest thing to stop any spread if you do have a positive patient. So we can probably go forward, I think, to the next slide, Melody. So now you have a COVID positive resident, and we're not going to go through, like Kelly and I decided, we're not going through all the protocols. You guys have gotten all those checklists, all the CDC, you have all the guidance. Our piece was really to focus in with what did we learn? What were some big takeaways that we discovered when we had a positive resident, when we had a facility with a positive resident? And of course, none of us want that experience. But the two of us have had that experience now with our facilities, and I kind of reached out to our one facility that has had a number of patients and said, what would you say is your biggest buckets of takeaway? And of course, the biggest thing that we just emphasized on the last slide was isolate immediately. If you have a low threshold, set that low threshold, isolate. Once you think you really do have something and you're sending out for testing, the fastest you can isolate out that unit, that wing, or that area that you've designated, and implement strict precautions in the way you manage it, the goal will be then you can stop any spread, hopefully, to the other parts of the facility. You know, the quickest you can go to dedicated staff for that area or that person, and stop any floating. I think most facilities are now doing really well of doing consistent assignments, so we're not floating staff from unit to unit. But if you think you've got something, especially if you do end up with a positive staff, you need to, it has to be correctly, or positive resident, you need to isolate out that unit. Our facility that had a number of cases, we were able to, and the facility did amazing. They were able to cut off that unit from the rest of the facility very rapidly. Nobody, including the administrator of DNS, crossed over that line. Very quickly, we identified it's a separate break room, separate entrance. The staff went onto the unit and they went out different ways. We changed all crossover. I think that it was able to stop the spread into the other units. And I think we all know communication is big. It's huge. We cannot, I mean, I think we all hear that and we talk the talk. We need to communicate. We need to communicate. But with the staff, one, they're scared. Our families are a little scared, and we need to make sure that we know what we are communicating, how we're communicating, and we do it quickly but calmly and immediately to the family and the staff. CMS has now updated new rules. I think Kelly alluded to regarding, was it May 1st or May 8th, when we have to do notifications. I believe most of us, including Kelly's buildings as well, have already had developed how we communicate strategies. And so just making sure that we're being concise and factual and empathetic. I think, like all of us, the goal is to get ahead of the rumor mills, get ahead of the media, so our staff know what's going on and our families before it gets out. And we need to be ready to listen. So as we are busy and knowing, oh gosh, we've got this COVID positive resident or residents or staff, you need to be able to say, as a leader in your facility or whatever, take the time to step back and be calm and be ready to take the time to listen and to exhibit the fact that you do have time to listen, even if the world around you is going crazy. Because our staff, again, they're scared. They need that empathetic listener. And I think many of us have heard from the lessons learned up in Washington is if you have a COVID positive facility, the phone becomes a floodgate. So having someone who's designated to answer the phone calls, that's not the nurse on the floor, that's not the DNS or the administrator, but someone who knows the information and can be calm and consistent with the person on the phone has been key. Anything else under the communication there, Kelly, that you had?
No, other than remember your stakeholders. I would recommend that you review all those folks even before you have a positive in your building, all your county commissioners, your local county health, reach out, touch base with them so that relationship has been renewed and reestablished prior to having to deal with COVID, because you're gonna have to call on them to help support you when it does happen, which it will. Eventually, it's gonna happen to everybody eventually. So renew those relationships.
Correct. And what you're going to find is that everybody thinks they have a right to know everything that's going on in your facility, even if they don't have a loved one that lives with you. And so you have to be aware of how you're going to handle those questions and calm the community around you. with some confidence in who you are. And I know that both Kelly's building and our building that we had that went positive were in small communities. So it's again, a little different than the urban feel, and the information that the community feels they need to know to relieve their anxiety and fear as well of what's going on. And then obviously with residents, once you have a COVID positive, we know we've already been monitoring our residents. You need to update, you need to increase all monitoring. So we moved all residents up to Q shift monitoring. And not only the unit that had a positive resident, but we did that for other units as well. You need to react as if all your residents are positive. If you do that, then hopefully you can lock down and stop the transition. If you're looked at the very low threshold, hopefully you can stop the transition before it has already spread through your building. And then obviously communicate and coordinate with your county health, Oregon Health Association. I should have put DHS on there. I didn't mean not to put them on there, but they also need to be communicated right away. It depends on the county where you're at, whether or not the county will support you or have the ability to support you in your testing needs. So just be aware, in the pre-COVID slide, I think we missed putting know your testing resources. Don't expect that the state is going to come in and do your testing. So Kelly's building was building number 1 in Oregon, and so they got a lot of attention. And so as I said, we've been hearing different consistencies between counties on whether or not they're going to test everybody, what they're going to be, but you need to be aware of that. But you need to consider that all your residents may be positive because of the subtlety and the rapidity of the spread. And then make sure for your residents, while we know that there's no actual treatment for COVID, there is supportive interventions. So be aware. AMDA put out some really good physician order templates possibly to consider to get interventions and orders put on your record for pain intervention, for some morphine, for example. Get ahead and get that oxygen order. As nurses, we know we can start and then get the order. How are you going to deal with the anxiety that comes with shortness of breath? We did crisis on a couple of residents. That's why I think Kelly mentioned the IV poles, but just to get them through the humps. But be aware that, do you have that ready? Are you going to have those resources ready for your nurse that might need that and that physician? And above and beyond, of course, you need your staff every day, all the time, and even more when you've got COVID sick residents. And so again, acknowledge their fear and show that empathy and understanding. It's surprising, it's amazing, the staff's response to crisis. There are so many that just way above and beyond. We had so many staff that says, I will work the unit, put me there. And so they're willing to take that on. But be aware, as Kelly mentioned in your preparation stage, if you know what you have for PPE, make sure that you're communicating and your staff have confidence that they have what they need to do their job safely. And I think we're now at a better place in May than we were in March with the state resources to get PPE. The supplies of PPE have improved, but there is a need to make sure your staff are confident that you, as your leader, administrator, DNS company, is that we hear you, we see you, you have supplies. And then continue to audit and monitor those safety. Once you have COVID, if you break the barrier of infection control, you're not going to get it out of the building. It's going to be really tough. We also used, as I said, we did not have anyone that wasn't assigned to the positive unit to go into that unit, including leadership, but we put Zoom technology on the laptops on the med carts, for example, so our facility can log in to the unit. We could still have a face-to-face like we are doing right now and say, hey, we're here, we're just upstairs, we're getting what you need, let us know what you need. Our job is to be resources for you and to reassure you. But it allowed that personal touch during that period of time. And then obviously staff crisis planning. If you have positive staff, if you have positive residents, you're going to have positive staff. How are you going to staff, and what does that look like, especially if you have staff that are truly sick and need to be off? And like you heard from Jack, there isn't a really good answer for that. And so just to be aware of your emergency planning for it, get creative. For example, we looked at therapists or PTOTs. They can transfer, they can change, they can do toileting. And if they're willing to be assigned to a unit or a non-COVID unit, that might free up some CNAs to go to the COVID unit. Fortunately, we didn't have to do that, but we had the plan. So just, you know, be aware those are their planning, but be ready to activate on those plans. So we've all talked with emergency planning. We put these great things to a piece of paper, make sure they're actionable. Before you have a COVID resident, make sure your teams on the floors have something that Saturday night at 10 o'clock, it's Murphy's Law, that's going to be your COVID first positive. That nurse who's on shift needs to know, this is what I do now. These are the steps I need to do while I call my leadership, but this is what I can do right now, and be confident in that. So anything else on that slide, Kelly?
No, well, other than OHA, nationally, SNFs are finally getting more attention and support, and that includes supplies that are starting to flow. But the OHA now has the capability of testing 9,000 kits a week, and have identified SNFs and congregate care settings in general as a higher priority. So don't rule them out as far as running your tests. I would, if you do get a case, like I said, establish a relationship with them early. If you get a case, first call, I'm probably calling as OHA to make sure that they can come and support you in that. Obviously, got a lot of other partners you need to talk to as well. And then we can't say enough about caring for the caregivers. I got a bigger presentation of this that has multiple slides on that, and that's only limited by your creativity and how you can support them. They're afraid to bring it home to their families. Allowing them to bring an RV, trailer, camper, and putting your parking lot, stay on site. We rented extra apartments nearby where they could self-isolate instead of having to go home to their families. So lots and lots of things that you could do to support the caregivers.
Right. I think that's it for that slide, Melody. If you want to change any, we're getting close to the end. So there's just one couple bullet points that Oregon Healthcare had asked, what is the most unexpected learning? And I think there's two big takeaways that Kelly and I both had is you'll find your most challenging families during this crisis are your most supportive. They've got your back and they are right there with you. And then again, we can't overemphasize the amazing resilience of our staff who are faced with the actual COVID. They're volunteering, they're dedicated, and they're positive. They want to get our patients well. They want to do what's best to get them there. And then we need, like Kelly said, is giving them the resources, what they need to be able to do their job safely and keep their families safe so that they can be there to take care of your residents. All right. Any questions that we have or anything else on that, Kelly?
No, that's great. Well, back to Mel for Q&A if you need.
If you have a question that you'd like to ask our panelists, please enter it on the question and answer pane. Do you have a recommendation, Kelly, for where people should look for resources for fitting the N95 masks?
Well, we looked to our local community hospital initially, and developing that relationship prior to having that need is probably the best advice I can give you. Once you have a need, I would still look there and then reach out to anybody and everyone from OHA on down. The biggest challenge we've had is the shortage of test kits for N95 masks. It's a specific hood system with a specific scent that needs to be verified, whether they can smell it or not. So that's a tough one because we have had a challenge trying to track those down ourselves.
Next question, what is the most common symptom you saw in the residents?
Kelly, do you want to go first and then I can talk about ours?
So typical, we had, the first time we had was 5 residents almost all concurrently on one day where they had respiratory issues. They had throwing fevers, they were having shortness of breath, and the typical respiratory issues that you expect. The symptoms we did not expect and that required a great deal of management. We had a physician who followed all of our COVID positive folks, so it was consistent on our approach, and that was pain management. Apparently well into the disease, that is a significant issue that needs to be managed. So that was one of the surprising symptoms that we saw.
Right, and I agree. Ours, the ones that we had, it was low-grade fever subtlety, as I mentioned, is this little 99, like they might have 100 and then go down to febrile for a day or two and then came back up to 99, coupled with a subtle cough and a little sore throat. But we didn't see, for most of the ones that we had that were positive, we had a total of 10 residents that tested positive, the big symptoms. And so I think we see through the news such a wide spread of symptomology. And now we've seen CDC keeps adding new things to the list. So just make sure that you've got a really low threshold. Don't expect high fevers, and not every resident is going to have acute onset shortness of breath. Pain though, about day 10, we did see a lot of discomfort. So
yeah, day 10 was kind of the critical period in the illness. That's our doctor would agree with that.
And that wraps up our questions. So thank you both so much. Any closing comments from either of you before we adjourn for the day?
Keep your fingers crossed that we're on the downhill side going into the summer. Hopefully it follows a flu pattern and it's a seasonal illness. As it gets warmer and we have more UV rays coming through, hopefully that bug's going to die off a little bit, but remaining vigilant right up to the, until they start loosening the restrictions is probably the best thing you could do. Continue to gather PPE a little at a time for, round 2, which will be next fall and winter. Unless they come up with a vaccine or a cure, we're destined to see this bubble back up next winter.
Right. 100% agree with what Kelly said. Is right now is we're kind of at that fatigue level. We're 8 weeks in. I think 9th week in is we're tired. Our patients are tired. I do think that we're doing some more focus with the social isolation factor with your residents. So make sure that we're staying focused. The other thing which I think people we need to be cautious about is doctor clinic visits have opened up. So watching how our residents, do they really need to go out for those doctor's appointments just because the clinics have opened? So there are some conversations that have started out this week. So watch your exposures with those. I don't know if there's been a specific guidance with it, but we've just said if it's not a really important doctor's visit, why are they going out? So the same rules on that one, just be aware. Our diligence will protect. So going forward.
Review your admissions policy. It's not business as normal going forward on the admissions, whether you're under an EO or you're not. There are a lot of new things that you should be considering when people are coming in, pre-testing, handling of their personal effects, from their clothing. I would highly recommend you wash any clothing that comes in with a new admission. We're trying to get back to business as usual as much as possible, but it's going to be a new normal. So you need to take a lot of those things. A lot of them are common sense, but get them codified in policy so that they're followed consistently.
I think so.
Excellent. Thank you both so much for your time today. We are so grateful for you to share with us your experiences. And thank you to everyone who logged in today. I do want to give you a quick reminder that OHCA has our COVID-19 resources webpage. If you go to OHCA.com, one of the very first graphics that you're going to see is of the COVID-19 to access that information. So feel free to visit that. We're updating it every day with new information. So please feel free to do that. Copies of these slides will be sent out, like I mentioned, along with your requests for CEUs. Do you have any additional questions or things that did not get answered today? Feel free to send me an email at mking@ohca.com. And we will work very diligently to get your questions answered. We are here to support you and are very grateful for your hard work, for you, your residents, your staff, everything that you're doing to keep each other safe, keep the residents and staff safe, and the community as well. So thank you, everyone, for all that you do, and reach out to OHCA if you need anything. Thank you all very much and have a wonderful afternoon.